Welcome to the Oral Surgery Fight Club podcast. This is a collection of mock cases in the field of oral and maxillofacial surgery in a question and answer format conducted on Zoom. Enjoy. 3 months was more than enough. We did a review Wednesdays, like it's up here, Wednesdays at 6 p.m. and Saturdays at 10 a.m. So we just review for an hour, and some weeks, to be honest, nobody brought a case. So it was just kind of talking through what we were studying at the time. But for the most part, we had a topic just about every week. Like I signed up for a few cases. Tarek, Sean, there are, a bunch of people signed up to both be an examinee and be an examiner in each of these things. So that was the first tip, is like, let's make a timeline. And if you guys are okay with that, I think I'm just going to change the dates on this and set a timeline. Because this was actually like it. I mean, it sounds a little sadistic, but it was actually not too bad of an exam to study for. I had a little bit of fun just kind of mapping it out. And it was amazing. In our 15-person study group, everybody passed. Like the practice is, making this timeline and then practicing. That's the most important part. The second thing I did was I loaded up sound bites for the no-brainer stuff. And what I mean by that is for the stuff like medicine, for the pathology entities, I kind of had just one little soundbite written down on a flashcard or something. It's a sentence that you can get out in less than 5 to 10 seconds, like diabetes. If someone asks you what diabetes is and you're thinking on the exam, like, well, shoot, diabetes is, like, you shouldn't be doing that. You're just wasting time. So for the basic stuff like diabetes, all these medical anomalies, whether it's myasthenia gravis, whether it's Parkinson's, whether it's AFib, different medicines or something like that, what it's going to be. And they'll probably ask you that you might have the question, like, what is X? And it's super helpful to just have that soundbite loaded and ready to go. So for instance, my little soundbite on diabetes was, it's a glucose dysregulation disorder. It can be divided into types 1, type 2. It's diagnosed based on blood glucose levels above 200 or more than 2 readings above 120 on, more than 2 weeks apart, or an HbA1c above 7. And that was just a quick way to, let them know, like, okay, don't, I know diabetes, and you don't have to poke and prod. But the more you load those sound bites up, the easier it becomes, because in some of these, they're only going to go after the relevant stuff. But if they detect, you're kind of floundering on something, they might kind of let you just waste time on it, and you don't want to waste time. So sound bites were super helpful, even for stuff like pathology, where it's like, what is, I don't know, what's a Warthin's tumor? And if you just think along the standard blueprint, like if you make these flashcards enough, it comes down to a blueprint where you can rattle off the disease entity, like what it is. You can list the signs and symptoms, like how it's going to manifest in somebody. And then you can basically say, like, here is where it usually presents, like anterior maxilla or, posterior mandible. And then how to treat it. And basically all pathology is basically, well, I'm going to biopsy and then possibly cut it out or watch it. Like, pathology isn't actually too complicated once you start, studying for it. It's really not that bad, but it is. There are a lot of entities that you just, the things that differ are the staging and the margins. So we'll get there. And then the third tip I had is just practice. Like, sign up, like on this timeline, just sign up to be the examiner and the examinee. And it'll be super helpful, because being in the examiner seat, you get to see how questions are going to go. how to line up questions, how to walk somebody through a case, and just the mentality of sitting on the other side. So when you're an examinee in the real thing, you do kind of get a sense of, oh, here's what they're trying to ask. Here's what they're pushing me towards. So I'll make this timeline for next week and I'll share it with you guys. And I think, sign up for as many as you can, even if it's a cruddy case or something like that. Just cobble something together. It's really helpful, even if it is very poorly made as an examiner. Or if you're just going through a case, from residency, like I am. But that's
You guys cover 2 cases per session?
It's like 1 or 2 cases. Like if you can see the screen still right here, like occasionally we'd bring like 3 cases, because like medicine and anesthesia, these are the if I zoom in here, like I go down to medicine, we brought 3 cases that day. Because medicine and anesthesia, there's so many different ways it can go. But I don't mean that to be intimidating. I just mean that it's a section that has a lot of, it's a broad section, but they can only go so far. You only have 12 minutes. It's not like they're going to, take you deep into the weeds on like fractional excretion of sodium or something like that on kidney disease. They're not going to go in to crazy detail. They're going to stick with the basics. I'd say the important things that I thought they were looking for is 1, make sure you're a safe practitioner. 2, make sure you're not going to kill a patient. And like, as long as you're just staying safe, you're probably going to pass. And as long as you're articulate, you're probably going to pass. Like you guys, I'm probably the weakest test taker out of all you guys. After being next to you, each of you guys for a number of years, you guys will all do fine, but it's just a matter of practice. Okay, so I brought 2 cases today. I don't know who wants one of them, 1 or 2. One of them kind of, I'll let you know, they're both pathology cases, but one of them kind of delves into reconstruction a little bit. So who wants a case? Sir, do you want one?
I'll take it.
You want one, Carla? All right.
I don't want it, but I'll take it.
I know. It was the same way in our study group. Like nobody ever wanted to sit in the hot seat.
So I want to be the first one.
I know. Do you want it? No, but do you need it? Kind of.
I'll accept it.
All right. All right. So I'm going to start the timer here. What time is it? 9:16. All right. Cool. So you get a 12-year-old female that presents to your office 6 weeks after hearing a crack in her jaw. 4 weeks after hearing the initial cracking sound, she had swelling. What do you want to know?
I want to know, medical history, surgical history, medications, allergies, anything like that. Also want to know what she was doing when she heard this crack in the jaw. Was it trauma?
Yeah.
Did she have any pain, any paresthesia?
Yeah. So she was chewing when she heard the crack in her jaw. She has no relevant medical history. She says her bite is different, and she says she has a little bit of tingling in her left lip. What do you want to do?
I want to get a orthopantogram. Is that what they call the panos?
Yeah, just just a little interlude here. This exam is purely what would you do, not like what do you think the answer is. So just keep focusing on that. What would you do?
I would conduct a physical exam.
Yeah, sure. So on extraoral exam, she has paresthesia of her left side in the V3 distribution. She has pretty significant left mandibular swelling. She's tender there. Intraorally, she's got mobility of tooth number 19, and she has tenderness like all around that kind of retromolar pad on the left side. You said you would get a pano, so your assistant snaps this image.
Hey there.
Can you describe to me what you see?
Let me make this smaller so I can see everything. So this is a orthopantograph of diagnostic quality. I see that the condyles are visible. They're round, seated in the fossa. Sinuses are aerated. She has.
What do you see around the left mandible?
I see a large radiolucent lesion associated with unerupted tooth buds 17 and 18. Also, I see some, the radiolucency extends from the sigmoid notch region over to the first molar, tooth number 19.
I understand. So what do you, what's on your differential at this point?
Macho, so myxoma, meloblastoma, CG, dentigerous cyst, hemangioma, and OKC.
Sure. So what would you want to do next at this point?
I would want a medical grade CT.
Sure. So you get a CT, and it shows you a pretty sizable lesion here, 4 centimeters by 3.5 centimeters. What would you want to do at this point?
I would want to get an incisional biopsy. I would probably consider putting the patient maybe in MMF.
That's pretty good. So she's a little concerned about this mobile first molar on the left side. How would you address it at this time?
I'll probably just put her in an MMF, have her in a.
I also forgot to mention there was no segmental mobility upon your exam, but that's while the examiners won't tell you, they won't give you any feedback to your responses. I'm going to say that's a good idea to put her in MMF. Okay, so you get describe your incisional biopsy.
I would make a crestal incision distal to tooth number 19, and I would make a distal buccal release. And
so while you're doing that, you discover tooth number 19 actually is really, really mobile.
I'll probably take it out.
You don't think it's viable? Okay.
I would expect it at that time.
So you do your incisional biopsy. Tooth number 19 comes out along with some tissue. It comes back as a ameloblastoma from the pathologist. Okay. You remove the specimen, and what would you do at this time?
I would start planning for resection and reconstruction.
The patient is a little averse to having her mandible resected, being 12 years old. She asks you if there's any other options.
I would try to decompress it, make it smaller.
The patient and her mother like this option. So you put in a decompression tube. And what would you expect to happen during the course of the decompression? How long would you wait? And what would you tell the patient and her mother about the next steps?
I would wait a couple months, maybe 4 to 6 months, continuous follow-up and checking on the size of the lesion. I think regardless, We're going to have to resect. It's maybe a matter of what size.
So you get this pano at the 3-month mark. Are there any changes you notice since the last one?
Yes, I see that the inferior border is, there's more of an inferior border. It seems like there may be some buccal or lingual bone that was.
Would you continue with the decompression at this time?
I would, yes.
Cool. So you tell her to wait 3 more months, and this is what it looks like.
Yes. I would continue.
Yeah. So you continue. You actually managed to get a CT at this time. At what point would you consider removing these impacted teeth?
Probably once I have, I guess at this point would be good. There is a nice inferior border. I
Sure.
wouldn't be as nervous about there being a fracture.
Yeah.
And
So you make at this time, you've said you would take out the teeth and enucleate.
I wouldn't nucleate just yet. I'd probably let it get a little bit smaller, maybe after the teeth came out.
Okay. What are the subtypes of a unicystic ameloblastoma?
Well, I can't tell you that.
Sure. So you wait a couple more months and you actually end up shelling this thing out, like enucleating it properly. It comes back as a intraluminal ameloblastoma. Is this consistent with what you've seen on images so far?
Oh, nice. No, I don't know that right now.
What? And that's perfectly okay to say. What's the recurrence rate after enucleation and curettage of an ameloblastoma like this?
Yeah, I can't tell you either.
Sure.
You got me.
So you take her out of arch bars. She's very happy. At what point would you consider this patient eligible for dental implants?
So she was 12. I'd probably wait until she stops growing, maybe do serial cephs or just follow her growth.
Sure.
And consider it after she's stopped growing. I'd probably get a denture in there to stop super eruption.
Sure. Okay. Well, that's basically the case. I thought you did really well there, Carla. That was really good. Especially going towards like decompression. It's a tougher case to just like make those calls. Like, what would you do? Because resection, it isn't terrible.
Yeah.
It's a viable option.
Yeah.
But the examiners, I got pushed around on a couple cases, where I suggested one thing and they said, well, the patient doesn't want that. And so they make you go down, they make you go down other routes. But you picked the right things, and like you did the right things by putting her in MMF. Well, I mean, if we go back from the very beginning, like, yes, medical history, asking her, those HPI questions, like, does it hurt? Is there sensation change? Is the bite different? You asked all the right things. And that's like a whole component of it. I think it's also in the ABOMS blueprint, like how they score you. Like you're eligible to get 72 points, something like that, during the whole course of the exam. And on each case, you basically can get like one of 3 points, and like you get 1 point for like just data gathering, or maybe they grade you on data gathering, kind of integrating all that data you've gotten into the correct diagnosis. And then the third part is making sure you have the correct treatment for that diagnosis. And you had all the right things, like you gathered the data right, your diagnosis of, having those entities, a myxoma, I think it'd be more mixed radiolucent, radioopaque, CG, yeah, that's just fine too. Ameloblastoma, dentigerous cyst, OKC, like those are the most likely ones. You called them out. And then the treatment of decompression, taking out the mobile tooth number 19, allowing it to decompress, like, and also putting the arch bars on because she said, she felt her bite was different. And I guess we could have also talked about what you'd recommend in terms of like post-op instructions to her, like soft diet, maybe limitation of opening and all that stuff. But yeah, I thought she did awesome. That was like textbook.
Nice.
Hey, would you want to get her like a removable partial denture to prevent the super eruption on the left? I see that tooth just came
Yeah.
down.
I
I gotta sharpen my swords for the oral boards. I learned them from Patel, and he's the Lord. And I'm his protege, you know I'm gonna slay all these motherfucking questions today. Cause I got the sound bites, they're gonna make these old men go, ooh, ah, like some afternoon delight. Yo, I got these questions in my sight, and I got the answers. Yo, my answers is so ill, they give you canker sores.
Thanks for tuning in to Oral Surgery Fight Club. For uncut episodes and sound bites, go to osfightclub.com.